Welcome everyone to tonight's Acts 2 workshop, Maximizing Health and Well-Being for Loved Ones with Dementia, special focus on palliative care. I'm Dr. Rob Glukoff, servant leader of the Acts 2 project and professor, Florida State University College of Medicine. In case you are unfamiliar with the term Acts 2, it stands for African American Alzheimer's Caregiver Training and Support Project 2. Folks, I am very excited about the prospects of tonight's workshop. Palliative care is both a much needed and highly effective option in supporting the quality of life of loved ones with dementia. Unfortunately, many caregivers and persons with dementia do not receive information from their healthcare providers about the wide range of services that palliative care offers. We plan to fill this gap tonight. Audience participants are strongly encouraged to ask questions and provide input during the course of this workshop. Before I introduce this evening's presenters, I want to recognize our partners who've contributed both resources and guidance in the development of the Acts 2 Dementia Caregiver Workshop series. Acts 2's primary collaborators are the African Methodist Episcopal Church 11th Episcopal District, the Florida State Primitive Baptist Convention, the Florida General Baptist Convention, the Florida Progressive and Missionary and Educational Baptist Convention, the Florida Church of God in Christ, and Florida State University College of Medicine. Turning now to tonight's presenters, we have three inspiring speakers: Chris Morissette, Fabiola Jean-Charles, and Tomeka Norton-Brown. I have the distinct privilege of serving as moderator for this evening's workshop. Please permit me just to share a few words about each of our featured speakers. Our first presenter, Chris Morissette, is a nationally renowned healthcare leader and network planner with over 20 years of experience fostering initiatives across chronic serious illness and long-term care settings. As Chief Strategy Officer of Olivia Care, he currently leads efforts to expand access to community-based services and builds integrated delivery networks covering hospice, home health, and palliative care. Prior to joining Olivia Care, Chris served as Chief Strategy Officer at Telios Collaborative Network, where he led strategic planning and network development for an alliance of hospice and palliative care providers. His efforts helped position Telios as the nation's first clinically integrated network for serious medical problems. Mr. Morissette believes that with every opportunity comes a chance to make a difference. The drive to make a difference in the lives of others is what pushes Chris in his healthcare service journey. Our second presenter, Fabiola Jean-Charles, is Director of Transition Supportive Care, sister company of Big Bend Hospice, a community-based palliative care program serving Florida's Big Bend region. She holds dual degrees in psychology and gerontology from the University of South Florida and a Master of Social Work degree from Florida A&M University. With over a decade of leadership experience in chronic illness care, Fabiola leads an interdisciplinary team dedicated to improving quality of life for individuals living with complex medical conditions. Her work focuses on symptom management, care coordination, helping persons with chronic illnesses and their families navigate health decisions while ensuring their care aligns with the personal goals and values of these individuals. Last, Tomeka Norton-Brown is coordinator of the Acts 2 project. She has served as a leader in survey development and evaluation at the Survey Research Lab for the past 25 years, and also doing the same activities in Acts 2. Tomeka has served as caregiver of her dear aunt and uncle with dementia and has a passion for helping others. She has been a great source of encouragement and support for literally hundreds of family caregivers across the state of Florida. Tomeka is also a strong leader by example in her church community. During the course of this workshop, I encourage viewers to share questions to be answered after each presentation using the text message function of Facebook Live or YouTube. We also will have a 20-minute question and answer period following the last presentation. And now, let's bring on Chris Morissette. Welcome, Chris.
Thank you, Dr. G. Great to be here this evening. Excited to talk about a topic I'm very passionate about, palliative care.
We're excited.
I'll go ahead and jump in. So I've had the privilege of working in palliative care now for close to 20 years. And I will be honest, I still struggle to spell this word. In fact, I actually had palliative care in my title for a period of time. And you can imagine how difficult that was. So again, my goal tonight, and I know the goal of Fabiola, is to really break down palliative care and to help you as caregivers understand what is this thing called palliative care and how do you access it and what's the real value to you as a caregiver as well as to the loved one you're supporting. And so I want to talk about palliative care and just really demystify what is palliative care. And palliative care is designed to be holistic support for patients and families. Palliative care addresses emotional, physical, and really the practical needs, providing support for both patients and families throughout this serious illness. The unfortunate reality, as we talk about demystifying, is too many healthcare providers still are unsure of or confused by palliative care and how to really offer that. And so if you're a primary care provider or even a specialist like a cardiologist or an oncologist or an internal medicine provider has not introduced you to this thing called palliative care, again, it's because really as a healthcare industry, we are still struggling to understand all of the benefits, and not all providers have really gotten their arms around this. And so we grace providers who have not been able to pass this beautiful benefit forward to you or your loved one. So again, our goal tonight is to really help you understand and maybe give you some tools so that when you go back to your provider, you know what questions to ask. And so thinking about that holistic support, it also provides expert symptom management. And so palliative care providers are trained. They are specialists in pain management, managing fatigue, nausea, anxiety, all helping improve the quality of life at any stage of illness. And so the best way to look at palliative care is this extra layer of support, not designed to replace primary care or other specialist work, but to really work alongside those providers as well as curative treatments to help support when that serious illness is really continuing to expand. And so palliative care is not limited to end of life. Too often we think about palliative care that it is hospice or it's only meant for end of life. Palliative care is not designed just for end of life. It's designed to be really support at any stage of the illness, collaborating with curative treatments to enhance care and outcomes. And so think about palliative care demystified as an extra layer of support. What do palliative care teams do? And so when you are introduced to palliative care, what is the role of that palliative care team and how do they work with your existing provider, primary care or other specialists? Primary care teams provide guidance in medical decisions. And so again, when we think about primary care, really designed to help you navigate traditional, cold flu symptoms, you go for your annual wellness visit. They're often not trained in the level of symptom management and things that palliative care teams are. So when we think about palliative care, they help families make complex medical choices that match patient goals, as well as aligning them around values, as well as that decision-making process once you're introduced with a serious illness. And so think about palliative care teams helping be that real guide through that wilderness of an advanced or serious illness. Palliative care teams also provide comprehensive care coordination. And so many primary care groups, many primary care providers have nursing and social work teams that help support a general practice or a group of patients. Palliative care teams have that extra layer of support to be able to go a little bit deeper and help provide additional coordination related to the serious illness. And so all of the specialists, the services that come with those specialists, really providing that seamless care, coordination of care for families as they're journeying through those stages of serious illness or advanced illness. And then they also support the emotional and practical needs for patients and families when navigating serious or advanced illness. And so receiving ongoing emotional support, practical help, really relieving stress, confusion, as well as just those crisis situations that can come up related to the serious illness. And so again, think about palliative care and the palliative care team is that guide or that extra layer of support when navigating our advanced or serious illness. So when do we introduce palliative care? When is palliative care really designed to come into the picture and provide that extra layer of support? Palliative care should really start when the illness burden increases, not at the end of treatment. And so early palliative care is the goal. And so, how early? Many folks, when they are first introduced, maybe they're told that they have an advanced illness, maybe they have the first diagnosis of dementia. Palliative care can begin that soon. So the earlier the intervention, the more support palliative care can provide. Identifying at-risk patients, so patients with multiple chronic diseases, frequent emergency utilization or visits, complex care plans. So again, if that primary care provider is introducing multiple specialists and your care plan for you or your loved one is starting to come and it's just more than you can manage on your own, that is a great opportunity for palliative care and really helping navigate those complex decisions that go along with that advanced illness. And then anytime that improved outcomes or patient experience is needed, early palliative care helps enhance that coordination, decision-making, experts in advanced care planning, as well as really helping to know when to go to the hospital, when to go to the specialist, how to really use your resources within the healthcare community to help improve that overall experience. And so the idea behind palliative care as that extra layer of support is to help improve the quality of life, but also at a lower cost. Many folks on the call today know healthcare can be very expensive. When you start to add in all these different layers of specialists and you add on top of that the need to use the emergency room or you have an admission to the hospital, all of that comes often at a cost as you engage your patient copay. And so palliative care, the goal is to help provide that support and in the end, improve your experience as a patient, improve the support to you as a caregiver support network or a family member, and then ultimately, hopefully lower the utilization of high cost resources like hospitalizations. So again, the goal of palliative care, earlier is better. Early palliative care provides that extra layer of support, helps improve your overall experience and reduce some of that burden that comes with the advanced or serious illness. It integrates the care coordination model, so you have a team around you to improve and support your decision making. And then it also just improves the overall quality of life and patient experience. The value of palliative care. So really clear communication across that care continuum. It's a term we use a lot in healthcare, the care continuum. What that means is you have primary care and you're advancing through with your primary care provider, as well as all these other specialists that really build that continuum of care or that broad care team around you. Palliative care can help with that extra layer of support by improving the communication and guidance that you or your loved one receive through that care journey. Palliative care offers clear communication and guidance. It also becomes an extra layer of support for the primary care provider. So often primary care make a referral to a specialist and then they lose line of sight over what's happening with you or your loved one's care. palliative care can become that guide in helping bridge some of that communication with your healthcare providers. We all know healthcare providers are busy. You've been in your primary care provider's office. Maybe you have a 15-minute, maybe a 30-minute, maybe if it's a more complex discussion, maybe your provider is able to give you 45 minutes or an hour. But often the follow-up they're able to do after is very limited. And so palliative care can, again, become that guide or extra layer support for that primary care provider, helping them bridge and understand what's going on with you or your loved one's care. It also helps minimize crisis decisions. And so when we think about palliative care and the value of this, and I believe Fabiola is going to get more into the details of this later, but removing that stress that comes from crisis decision making and ensuring that choices match individual values and healthcare needs. We have all had this experience. If you're a caregiver, I certainly have had this in my own life, trying to talk to a loved one who's journeying in advanced illness and asking those questions about what do you want the decision to be if something were to happen. Let's say you were to have a decline, a slip, a trip, a fall. Maybe your disease takes a turn and you're now needing more care. Palliative care can help minimize those crisis decisions. So we're making those decisions ahead of that exacerbation or that fall or that episode that happens. And you're able to make a decision that's truly in alignment with the goals of the patient, the family, and the caregiver. And then again, we talked about this, but supporting the well-being. Palliative care fosters confidence, peace of mind, and supports the well-being during the serious illness. And we all know, we've all been there, either on our own or with a loved one who we're caring for. Serious illness takes a toll. That advanced illness takes a toll. And so being able to have that support through that and around that emotional well-being for you or your loved one to remove really the stress and the anxiety that comes with advanced illness. So how is palliative care paid for? Palliative care is designed to be expanded support, but not an extra burden. And so often insurance coverage includes Medicare for traditional Medicare, Medicare Advantage, Medicaid often will cover the cost of palliative care, as well as commercial insurance plans. And so most healthcare insurance coverage does have a palliative care benefit. Palliative care is billed like traditional medical visits. In the world of Medicare, there's Medicare Part A, which is traditional hospital coverage when you go to the emergency room or end up admitted into the hospital. The follow-up from that is covered by Medicare Part A as well as hospice care. And palliative care as well as traditional Medicare is covered under Medicare Part B. So it's billed just like primary care or any traditional Medicare. And again, there's no need to stop other treatments with palliative care. Palliative care patients can continue to receive care from their primary care or other specialists, and those providers continue to bill as they were. So palliative care is a benefit designed for you. And again, most insurance coverage, most of your current existing coverage will cover palliative care. And so in my last couple of minutes, I do want to talk about a special program for those that are on traditional Medicare called GUIDE. This is specific to patients and caregivers who are navigating dementia. And it is a part of a palliative care benefit that Medicare just released in 2024. GUIDE stands for Guiding an Improved Dementia Experience. And it's actually a demonstration benefit right now under the innovation arm of Medicare. And so if you hear of CMS, the Centers of Medicare and Medicaid, this is a special benefit under CMS or Medicare, currently designed to support individuals living with dementia and their caregivers. This provides care coordination, education, and 24/7 support, as well as respite. Again, this is a palliative care-like benefit directly under Medicare today for traditional Medicare patients. Why GUIDE matters. This is for anybody who is caring for or has dementia that is under traditional Medicare. And GUIDE helps support caregivers navigate the care system, feel more confident, as well as access the help that they need. So just as we've been talking about palliative care and what is palliative care, GUIDE provides an extra layer of support specific to the dementia diagnosis, empowering families to help keep loved ones home and safely home longer. Features include caregiver education and training modules, 24/7 support, as well as access to respite services, which means that a provider can come into the home. A home care provider can come into the home for a certain set of hours, or you can access these respite benefits in the safety and the care of an adult day center, or even in some cases, an overnight facility. Guide helps caregivers thrive through reducing caregiver stress and burnout, providing tools in handling challenging behaviors, enhancing communication as well as planning. It improves caregiver quality of life. That's one of the primary goals of Guide, is to help really support the caregiver, many of whom are on the Facebook Live today. Don't have a lot of time to go into this, but I'm going to just quickly talk about one story in particular, Bill. Bill was a caregiver, husband of 45 years. His wife was diagnosed early with Lewy body type dementia, required her to move into an assisted living, and Guide provided care navigator, streamlined support to Bill, as well as the caregiver team that were supporting his wife, and provide that extra layer of support for Bill and his loved one, his wife. And this was the exact reason Medicare created this, was for people like Bill and his wife to get that support that he needed, to give him and his wife that extra layer of support as she was journeying her advanced illness. So how do you engage Guide? What does this look like? Again, it is for traditional Medicare beneficiaries with a dementia diagnosis. You must be living in the community. It's not available for those that are in the skilled nursing facility. It works with, but does not replace, existing healthcare services. And exclusions include Medicare Advantage, enrolled in PACE or hospice, or living in a skilled nursing facility. And so, unlike traditional palliative care that is billed Medicare Part B, Guide is a specific dementia-focused palliative care benefit that meets these criteria. And we will provide this resource, but if you're interested more in Guide specifically, there is a link here. You can actually go onto the Innovation Center website and find a Guide program near you. And so with that, Dr. G, I believe that I am at my time, but I will have my contact information here, and happy to field any questions now or at any time after this presentation.
Thank you so much, Mr. Morissette. That was excellent. Excellent presentation. Very comprehensive. We do have a question for you, which I'm sure you can answer. Carlos Olivas has asked, is the Guide program one that has financial limitations?
So, Carlos, great question. Again, the limitations with Guide are really around the exclusions today. So if you or your loved one have traditional Medicare, this benefit was designed for you. And unlike some of the other services that come under Medicare, where it requires a copay, Medicare, CMS has waived all copays for this special dementia program. So there is no financial limitations here. Everything that I discussed in Guide, including the respite benefit, the caregiver support, the 24/7 hotline, all of that is inclusive to the Guide program. Now, I will say Medicare Advantage, so the Aetnas, the Humanas, some of these larger Medicare Advantage plans are now starting to offer similar benefits to Guide, but they calls it something different. So if you talk to your insurance plan and you're not under traditional Medicare, you can ask for, hey, could I have something, or do you offer something like the Guide program? And as healthcare leaders, we're actually putting pressure on Medicare Advantage to try to increase their benefit offerings so that it is not they can offer something similar to what you could get through traditional Medicare.
Thank you so much. We appreciate these requests for information from Mr. Morissette. Caroline Collins has asked you, Chris, why are SNFs or at skilled nursing facilities excluded from Guide?
Great question. So typically skilled nursing facilities under short-term Medicare Part A are providing short-term rehab. And those are covered under the Medicare Part A benefit. And then the long-term care side, the skilled nursing facility, is often a combination of Medicare or Medicaid rather. And so they've excluded that because of some of the duplication of, and the design is when you are in a skilled nursing facility, that becomes custodial 24/7 care. That's either covered as a private pay or by Medicaid. And so Medicare has made some assumptions that 24/7 support is under the guidance of a professional caregiver. The reason assisted living is included in that is because that is a domicile or residential environment that you're purchasing services through the care delivery system at the assisted living, but it's not typically paid for under the same Medicaid, Medicare type of a model. So again, they're looking at it as duplicative services in a skilled nursing facility, not the same in assisted living, where that becomes basically the non-custodial care. It's their home. I hope I explained that well enough. But the difference between skilled nursing and assisted living is still considered the residential home, and they're extending that guide opportunity in assisted living. Great questions.
Thank you. Chris, I think just in the interest of time, I'm going to hold back on my own questions for you, and bring them up at the panel discussion 20-minute slot at the end. Thank you so much. And now we have Fabiola Jean-Charles. Thank you, Fabiola, for bringing your expertise to bear at this evening's workshop.
Thank you, Dr. Glukoff. Great presentation, Chris. Hi, everybody. My name is Fabiola Jean-Charles. I am pleased to be here with you this evening. And for my part of the presentation, I do want to tell you more about what a visit looks like from the palliative care team at home. We'll talk about signs that you need to ask for palliative care sooner. We'll go into what disciplines make up the palliative care team, as well as myths that you may have heard about palliative care, and I'll close with how to access palliative care support. All right. So while palliative care is provided across a variety of settings, such as hospitals, outpatient clinics, and at home, I do want to tell you what a visit at home looks like from the palliative care team. So our team we start with meeting the patient where they are. We listen first. We try to understand what matters most to the patient and their family. We focus on what helps. Our nurse practitioners will look at symptom control, review medications, and make sure the plan that the patient has makes sense for them. We focus, we connect the dots. We help coordinate between specialists and treatments that the patients have, and settings so that everyone is on the same page. And we support family caregivers too. We understand that this journey can be overwhelming, very complex a lot of times. So we want to make sure that family caregivers have clarity, coaching, reassurance, and we're just not focusing only on paperwork. During the initial visit, however, we do go through some consent documents. I know our nurse practitioners will provide education about what palliative care is, explain the benefits of palliative care, and really educate the patient and family on ways to help improve the patient's quality of life. And of course, we'll talk about advanced directives so we can get on the same page and we know what the plan is. We'll discuss goals of care, what is important to the patient and family. I apologize. I'm sorry. Again, I mentioned we'll review medications and we'll educate the family so they can make the best medical decisions possible for their loved ones. Next slide. So this is a comment we got from one of our patients, caregivers. They said we were very supportive to them and we helped them navigate. We were there every step of the way to support them, which was meaningful for them. I think I went a little bit ahead of myself here. I apologize. I think we reviewed these already, so I'll go on to the next one. So some signs that families should really be looking at asking for palliative care sooner. And these include, when the patients have many specialists, but care, there is not coordination, not enough coordination. When care feels fragmented, when symptoms are becoming not only increasing but becoming difficult to manage, that's a sign that caregivers should be looking, and patients too should be looking at engaging palliative care support. Um, there starting to be repeated ER visits and hospital admissions, and that's creating crises, and we want to get involved with the patients and families sooner so we can help them plan for the future and prepare for these crises before a crisis occurs. And families feel overwhelmed. Again, this healthcare system is very complex, and it's difficult for a lot of people to manage. So if patients and families get connected to palliative care, they'll get that expert guidance from the team, so they can really be getting the information they need in order to make the best decisions they can for their loved ones. Um, the encouragement here is to not sit idle, to do something, to get information, to take action. Don't wait until a crisis occurs to respond, to react. I think that's when a lot of caregivers and patients may experience dissatisfaction, unfortunately, with palliative care, is because they're oftentimes engaging palliative care at a time of crisis. And in those times, there's not enough time for the palliative care team to have built a relationship with the patient and family, to get to know what's important to them and put a plan in place, so that we can more meaningfully support the patient and family. And as far as the palliative care team, of course, different palliative care programs teams will look differently, but traditionally, palliative care programs have a team of an interdisciplinary team of physicians, nurse practitioners, nurses, social workers. Some have nutritionists, dietitians, and other like disciplines. But I'll go over what the nurse practitioner does on the team, and they're really the glue, the center focus of that team, that support for the patient. Like Chris mentions, palliative care doesn't take over care. We're not a replacement for the patient's primary care physicians or specialists they're working with. We want to work in collaboration with them. So the nurse practitioner will help with that, with that collaboration. They'll focus on they'll assess the patient at every visit, taking vital signs, and make sure that they complete a full assessment to understand what symptoms are occurring, what symptoms need attention, and how best they can support the patient. And of course, educate the family so they can make the best medical decisions possible. They do with every visit, review medications and prescribe medications when necessary. They'll often order durable medical equipment, so hospital beds, wheelchairs, whatever the medical equipment is that may be necessary to support the patient's quality of life, the nurse practitioner will order. And they also will order home health services. So if the patient has a need for physical therapy, speech therapy, occupational skilled nursing, the nurse practitioners can order that for them. As far as our nurses really help in between visits, especially between the times that the patients go from seeing the providers. So they'll continue to offer that education, and under the providers' request, they'll monitor various symptoms for the patient. And they'll provide that practical support and help triage calls as they come into our office to help better manage the patient's care. So, as far as our social workers, what our social workers are able to do, they're an essential part of the palliative care team, because while the nurse practitioner and the nurses are focusing on the clinical aspects of the patient's care, our social workers really focus on the emotional support. Really understanding what gaps may exist in the patient's environment, what additional resources and services they could benefit from, so that they can help them navigate those, and again, really help to advocate for the patient to get the support they need, because there's a lot resources that may exist within, your communities that you may not know exist. And that's where a social worker comes in. And lastly, for our team, we have wellness callers, and those wellness callers are dedicated and trained volunteers. And what they do again is between those visits with the providers, our wellness callers are getting on the phone, calling the patients to see how they're doing, if they're experiencing any new symptoms, if they've been to the hospital, what is it that they're navigating right now that needs attention, so that our team can intervene and really support the patient and family. And next, I'll go into some common myths about palliative care. And, unfortunately, there's a lot of misconception between hospice and palliative care. And they're not coterminous. They're two different types of support for patients living with serious chronic and even terminal illnesses. And we hear a lot that patients think it means giving up. Getting palliative care support means giving up. And that's not the case at all. Patients don't have to forego treatment. They can continue to receive their treatments. Like Chris mentioned, they're just getting an additional layer of support that is really designed to improve the patient's quality of life, provide timely response to symptoms, really helping to educate the patient and family so they can make decisions, the important decisions, as the disease progresses. So it does not at all mean the patient and families are giving up. Next is that is for the last days of life. Again, Chris spoke on that earlier. Palliative care should be engaged as often, in my opinion, as soon as the patient is diagnosed with the serious or life-altering illness, because that really gives the palliative care team an opportunity to get to walk alongside the patient as the disease progresses, put a plan in place, understand what's important to the family, so that we can prepare for crises. When symptoms increase and we need to act quickly, we can help the families as they go through these experiences. The other myth we hear is that it replaces regular doctors, and it absolutely does not. We have to work in collaboration with the patient's primary care physicians and specialists, so we can better wrap our arms around the patient and more meaningfully support them. So we don't replace anyone. We can coordinate with the primary care physician. We coordinate with the specialist, so we can all be on the same page, because we all have the patient's best interests at heart. So we don't replace anyone. We add to, we don't take away from what the patient comes into our care with, and they can add more as they engage our services. We hear that it means it's the same as hospice. Again, hospice is, care care for the last 6 months of life, end of life care for the last 6 months of life. Whereas palliative care, patients can continue to receive alongside treatment, and oftentimes can be on palliative care for a number of months, years, etc. So as long as the palliative care support is necessary, it is impactful to the patient's quality of life and care, palliative care will continue to engage. And there's one more myth I didn't get a chance to add to the slide here I want to share. Is that engaging in palliative care support means that you're not strong enough or you're not capable enough to do it yourself. And that is not at all the case. I'm confident that, the patients and caregivers are very capable, but you need help also. It's okay to engage in help and engage in that help as early as possible. So you don't have to do it alone. And how patients can get connected to palliative care. There are a variety of ways patients can engage palliative care. You can get a referral from your doctor's office, and as well as calling directly to us to learn about the patient's eligibility for palliative care support. And add here that, while we are transition supportive care now, Big Bend Palliative Care, we're operating in the 8 counties in the Big Bend region. For anyone outside of this area, if you're looking for palliative care support, there's a fabulous website called getpalliativecare.org, where you can search for palliative care support in your area. So please feel free to use that website to engage palliative care services, as it is of utmost importance. So I encourage you to look there. I will go on to my next slide. The point here is, ask early, ask questions. Don't navigate serious illness alone, because for a lot of patients and family, for a lot of patients living with serious illness, they're living with those illnesses for a number of years, and there's help available. And if palliative care can help you, if any other local organizations can help, I really encourage you to take part in that support. Um, I am. I know I'm ahead on my time. Any questions from anyone?
Thank you so much, Fabiola, Jean-Charles. Very, very well done and comprehensive. I have a couple questions for you, and if we have others that are brought to the table, Esperance, our social media coordinator, will put them on the banner below your and my video shots. Uh, First question:
Yes, sir.
can you describe how the palliative care provider operates as the point person for the network of healthcare providers or professionals that a person may have? What are they actually doing to serve as point persons? How do they connect with other providers and provide that information to the person with the condition and their family care partners?
hmm So that's a wonderful question, Dr. Glukov. Thank you for that. So our nurse practitioners, in going to the patient's home wherever they are, they're able to see a lot more than a traditional primary care physician and specialist might see. So our nurse practitioners, in having that knowledge, and really managing more quickly symptoms of the illness the patient is living with, are not only acting quickly, but also we're communicating. Our providers are oftentimes calling the primary care physicians. They're calling the specialists to let them know, especially when it has to do with medications, because of course we want to be respectful, right? We want to collaborate with the patient's providers. So we do want to notify them anytime we make any medication changes, anytime we order additional equipment. If we're ordering home health services, we let them know. And our nurse practitioners with every visit document the visit, and those notes are shared directly with every provider we know the patient is working with. Now, I'll tell you, it is important for the patients and families to tell us who they're working with. Sometimes patients come to us without a primary care or without any specialist, and they acquire them as they remain on service with us. So our providers are always checking to see what's changing, who else is in your network of care that we need to be notifying that we're involved with you. So everybody can have the information at their fingertips and could be more aware of how our team is helping to support the patient. I hope that answered your question.
Oh, that was excellent. I even have a follow-up. It was so good.
Okay.
As you know, I am a user of palliative care services for my wife with dementia. If I were to have a concern, or my wife and I might have a concern, could I ask the nurse practitioner who visits us at our home to coordinate with a provider for which we have questions that maybe have been unaddressed by that provider?
Yes, and that is something we unfortunately see. Again, we're all in this together. Our primary focus is the patient's quality of life, and anything that's going to make that journey easier, not just for the patient, but for the caregiver. So we get oftentimes, caregivers coming to us and asking us to help advocate for them, especially if their questions, concerns have gone unattended to. Our nurse practitioners or our team are able to call and say, hey, I'm here, I'm from this program supporting this patient. They've brought to my attention that they have this concern. How can we how can we resolve this for the patient? How can I help you? If it's something that our team can do to help push that along, resolve whatever the issue is for the patient, we're certainly happy to intervene. So our nurse practitioners will make the call, or nurse will, anyone from our team, we're more than happy to step in and help advocate for you. Absolutely.
Excellent. Well, I have other questions, but like I said to Chris, I'll say to you, I'm going to hold them back until we have our panel discussion.
Okay.
Thank you so much. And
Thank
now
you.
we have Tomeka Norton-Brown, Acts 2 Project Coordinator. Thank you, T, for joining us this evening.
You are welcome. It is always my pleasure. And good evening, everyone. What I'm going to do is to provide information on our Acts 2 project and the services that we provide. Next slide, please. For our program of services, we have three major types of services. The first is our faith integrated group skills training and support for distressed African American caregivers of older adults with dementia across Florida. That is our 12-session program, which I'll give a bit more information on in a moment. We also do dementia awareness presentations and workshops at faith community and elder care venues, as well as social and print media across Florida and the U.S. And we do individual telephone-based problem solving and information and referral consultations to all dementia caregivers and other stakeholders across Florida and the U.S. Let me say that for our 12-session program, in order to qualify, you must be African American or Black Caribbean, residing within the state of Florida, providing at least 6 hours of caregiving, but that person does not need to live in the home with you. The individual telephone-based problem solving and information and referral consultations, as we said, that is a service that is available to any person, regardless of race and regardless of location across the U.S. And all of the services that we provide are absolutely free. Next slide, please. To give a bit more information about our 12-session program. This program includes 7 group skills building. So we pair 3 caregivers in a group, and then 5 individual sessions. All of our sessions are delivered weekly over toll-free telephone by what we call trained lay pastoral care facilitators. And our facilitators are simply persons from the community, so non-pastors, lay people from the community who have either been nominated by their adjudicatory leader or they self-nominate, and we train them to deliver the actual 12-session program. In those individual sessions with the facilitator, those 5 sessions, they focus on goal setting and problem solving to address those concerns that have been identified by the caregivers. So most of the caregivers who come into our program have 2 or 3 that they want to work on. One of them may be, how do I get more information about palliative care? We would then refer them to the partners that we have on tonight and others to make sure that they get the information that they need. Next slide, please. Our 12-session program has 6 major components. So the first is an overview of the basic characteristics of the dementias, or I call that Dementia 101. Every person who comes into our program gets information on what is dementia, what is it, what are the signs, what are the symptoms. We also teach relaxation training that's combined with calming prayer and or meditation. We actually teach our caregivers how to have mind, body, and spirit enter into the state of relaxation. We also work with our caregivers on effective thinking about the challenges of caregiving coupled with scripture, just changing the way that you think about your caregiving situation. As you've noticed, I've talked a lot about prayer and meditation in scripture. Acts 2 is a faith-based program, which means that we have woven those elements into the program, but we are also ecumenical. So if a person does not profess a particular faith, it prevents us from providing our services to them. Please. We also work on, I call it the me time module or emotional well being, just being able to build in pleasant daily activities as a guard against emotional distress. Just negotiating, hey, I need 15 minutes to take a walk or to listen to my music. We also work with our caregivers on communicating effectively, not only with the care partner with dementia, but with family and health professionals. And then lastly, developing those effective problem solving skills through that personal goal setting. Next slide, please. When we talk about dementia awareness training, we will deliver both in person and virtual dementia awareness training to family caregivers and other interested parties. Some of the example topics that we cover, we talk about the basic information about the characteristics and stages of dementia. We talk about risk factors for Alzheimer's disease and related conditions, and then also strategies for preventing or delaying of dementia. Next slide, please. For our individual problem solving consultation, once again, this is available to any person, regardless of race, regardless of location across the U.S. So, 1 or 2 problem solving sessions are delivered over our toll free telephone by our ACT2 staff members. The caregiver will prioritize 1 or 2 goals, and we work with them in developing an action plan. So some of the more common problems we work with caregivers on are they're having difficulties with bathing and hygiene for their loved one. They're having challenges getting their loved one to eat, and also difficulty getting help from family members. Next slide, please. Okay. For our information and referral consultation, once again, available to any person, regardless of location. 1 or 2 INR sessions also delivered over our toll-free telephone by an ACT2 staff member. That caregiver will prioritize their INR goals, and we work with them in developing an action plan. So some example INR concerns, they want help identifying affordable caregiving services. They want help finding culturally responsive adult daycare centers. Who are the people that are at the daycare center? Do they have activities? Do they take field trips? That type of information. And they also want help locating effective estate planning assistance. Next slide, please. We have included some dementia care resources. There's the Florida Department of Elder Affairs. There's the Alzheimer's Association, the Alzheimer's Foundation of America, the Elder Helpline, the Elder Care Locator, and the Alzheimer's Disease Education and Referral Center. Next slide, please. If you are interested in learning more about ACT2, you can reach us by telephone, by email, or through the web. You can contact us toll free, 1-866-778-2724. My local to Tallahassee cell phone number, 850-274-4945. My email address, tnnorton@fsu.edu. You can also go to our website, www.ax2project.org, or you can reach us here on our Facebook page, AX2 Caregiver Project. What we're now going to do is we're going to take a tour of our AX2 website. So if you would bring the website up, please. Okay. On our website, we have configured it so that there is a lot of useful information for caregivers. We provide information on our program of services, similar to what I spoke about in terms of what our program can provide. If you would click on caregiver resources. One of the pages that I use most on our website is our caregiver resources page. We have a link to our video archive. So every Facebook Live that we have done thus far is in that video archive. We also have prayers and readings. We have information on the basics of dementia. We also have information on caregiver well-being. It's a great place if you want to just see information regarding specific things. You don't have to go and search. We've kind of compiled everything. These links will take you out to not only Florida resources, but national resources as well. There's great information if you're dealing with difficult behaviors for your loved one. There's information there as well. If you would now click on donate, please. If you're interested in learning about how the Acts 2 project is funded and or interested in making a donation or investment to Acts 2, you can find that information here on our donate page. Okay, if you will go back up and click on contact us at the very top. If you want to send us a message, if you have a question, if something you think about after this live, or if you just have a question in general, you can fill out this contact us link on our website. It will route to my email address, and then we will gladly make sure that we reach back out and answer any questions that you may have. And what we're now going to do is bring all of the panelists back up so that we will have our panel discussion.
Well, welcome back. I do have, as I mentioned twice, questions for everyone. I think I'll start with you, Chris. You're the one, I guess. I think this is a question you could handle very easily, but I thought it might be important to the audience. How do you negotiate new symptoms or issues that are emerging in the course of a serious illness? As serving as the palliative care provider among other providers, how is the decision made by the palliative care provider, who may hear it first, to direct the family member with the condition and their family caregivers to seek symptom management services?
So I'm going to use a football example with Dr. G. We talked about football, right? I mean, we're Florida fans, and we may be Georgia fans, and we're going to use football. Hopefully there's some football fans out there. The way Medicare looks at healthcare is there needs to be a quarterback, just like in football. And that quarterback is, by Medicare's perspective, the primary care provider. So when we think about that, the primary care provider is really the one that is supposed to have line of sight to be able to support and direct care across the care continuum. And then we have all these beautiful specialists like cardiologists and pulmonologists. There's so many ologists. Would we not agree? Right? There's so many. I was listening to a podcast the other day, and once upon a time there was just a doctor. Now there's a doctor of everything. We have all these ologists, and this can be really challenging. Right. So we think about the quarterback being primary care, not always being able to see the field. Where palliative care comes in is palliative care is a specialist designed to help support a patient and a family through that care journey. So they are helping journey that through. They're asking questions that maybe no other specialist or ologist asks. And they're then working with that quarterback, the primary care, to help coordinate care. So they may hear things first, whether it's the palliative care nurse practitioner or a physician or a social worker. They may hear things first, negotiate that, to use your term, with the patient to help really identify the goals. What are your goals as you're journeying the serious illness? And then they feed that information back to the primary care, or at other times, other specialists, maybe the oncologist or the cardiologist. But palliative care becomes really that glue, that special extra layer of support to help advocate for the goals of care and the needs of the patient and the family, the caregiver.
Thank you. Fabiola, do you have anything to add or to about this issue?
I love Chris's answer, and yeah, everything he said is absolutely true. And one more thing I would add is that there's different ologists are very busy. They're taking care of a lot of people, thousands and thousands of them, right? And I think part of the beauty of palliative care is that we can make time. Our providers will make time to sit and listen, and as these concerns arise, and as these symptoms, show up, our team will be able to work, like he said, with the primary care physician or whichever the appropriate specialist is to really get care to the patient quickly.
Thank you.
Thank you.
Got to have another question for our palliative care duo. I don't mean to neglect you, Tomeka. I'll have a question for you later. Here's the question. We'll start with you, Fabiola, this time.
Sure.
Are there any other benefits of palliative care that we haven't discussed at this point? I have one to share as a consumer of it, but I thought I'd start with you because there is a plethora, wide range of benefits that palliative care confers.
Yeah, absolutely. Again, I think it's providing that support that caregivers and patients often may not think that they need, right? They're going to the primary, they're going to the specialist, and sometimes the care feels fragmented. So really, like Chris said, to have that glue, that palliative care team to help make sense of this puzzle, is really important. And we get patients and caregivers coming to us saying they wish they had engaged palliative care sooner. They wish they'd known about this when they were caring for whomever. And really, I can't speak highly enough of really connecting with a palliative care team as soon as possible. I think the more information patients and caregivers have, the better decisions they can make about their own cares or their loved ones' care. So I think the benefits are vast, for sure.
Thank you. And Chris, same question. Any other benefits that you'd like to punctuate?
I'm going to add one really tangible benefit. In the medical world, in the healthcare world, we call it medication reconciliation. What it means in real life is figuring out all of the medications that are in that cardboard box that are sitting on your counter. And I'll never forget, and I'm sure Fabiola has had the same experience being in healthcare as long as I have, done numerous visits alongside some of our medical professionals and nurse practitioners and physicians alike. But I'll never forget this lady, this patient, beautiful woman, multiple specialists. And we went to her home and she literally took a cardboard box out from a cabinet and said, "Will you just help me figure this out?" Documented it as medication reconciliation, but it was looking through what's expired, what's not expired. There's medications that don't always work together. Again, there's a term for that, medications that contradict each other, but just a palliative care provider very tangibly can help with that, right? And that's just a very simple benefit. But somebody sitting in your home, in your living room, at your kitchen table, walking through the medications that you may not ever have the chance to show all your ologists, all your specialists, or your primary care provider.
Yeah,
Absolutely.
I just like to add my own personal benefit. Working with our nurse practitioner from transitions with Fabiola's group, we were given a list of helpers to contact. I had a chance to interview them, and now we have one from that list who's working regularly with my wife, who goes hiking with her. They hang out together. It's to have that list of trusted helpers who are extenders of care in the community, vetted by the palliative care service, was a significant benefit to my dear wife and me.
Oh, thank you for sharing that, Dr. Glukov. I mean, as you all know, respite and in-home care is very important, to the patient and the caregiver. And that's part of what we've been trying to say about, not waiting to seek support, not having to do it alone, because, Google has a lot of information, right? But it's not oftentimes consolidated. It's not it, it it really helps to have the palliative care team to be able to point you in the right direction, especially when you're unsure or overwhelmed and don't even know what, or have had bad experiences with other carers, right? That matters too. So I'm glad that this was able to help you. If I could add one more thing really quickly, as far as a benefit, I like to say that, having palliative care team on your side really connects you to having somebody in your back pocket. Like, you have a team you always carry with you. Our office is open Monday to Friday, 8 to 5, but we also offer telephonic after hours support. So if there's a question, and those calls are answered by our nurse practitioners themselves or clinicians. So if there's a question, if there's a concern that comes through in the evening hours, in the wee hours of the morning, our nurse practitioners will get on the phone. They'll triage the situation. If they need to order prescriptions, if they need to schedule an appointment for the next morning, they will do that. So having access to that type of response is meaningful.
Thank you.
Yeah.
Tomeka, do you have anything else to add?
No, I've just been taking it all in, and because I learned about palliative care as we kind of prepare for this Facebook Live, and it's helpful to me so that when caregivers are calling up X2 and they want to know, what is this? How do I go about connecting to it? It's good to have the information to say this is what it's about, and then being able to pass them off to people that I know and trust. I never want to put a caregiver in the hands of an unknown. I always want to be able to kind of send them to someone that I know will give them the proper information and will kind of guide them in the right way. So this has been fantastic for me, just to kind of learn about all of the different things. And even in my own family, I have, aging in-laws. I have aging family members. I have family members that have chronic illnesses. So just to kind of keep all of this stuff in mind, even as it relates to my own family, has been really good.
Excellent. Have another question for you. I generated at least 10 questions while you were talking. Forgive me.
Keep them coming.
Okay, so this is for you, Chris, as a starter. I'm just alternating between you and Fab. Try to be systematic about that. What are the differences, if there are differences, among palliative care services that are offered at hospitals, clinics, and in the home setting? Or is that a misconception that somehow they're located in one area primarily versus another? Your thoughts, Chris?
Sure. So palliative care is available in the hospital, and often either the hospital itself has a group that provides that care, or like in our case at Allevia Care, we provide palliative care at most of the hospitals in our service area. And Fabiola, I'm assuming your program does as well. And the goal in the hospital is really to stabilize. And so let's say an individual comes in to the emergency room with an advanced illness. Maybe they've been journeying that for a while. Maybe they've been putting off going through some of these difficult decisions. And so they're now admitted, and they're now realizing, wow, this advanced illness, this serious illness is complex and I need more help. The goal of the palliative care team in the hospital is to help stabilize and then begin the planning process, that advanced care plan, goals of care. What does care need to look like as we leave, partnering with the care coordination team, the social work team upon discharge. So there's a plan when that patient goes home or to a short-term rehab. And then there is outpatient palliative care, which is typically in a clinic setting, sometimes embedded, often in an oncology clinic or sometimes a cardiology clinic. Again, the ologists, realizing that they don't always have the support, the bandwidth, or the time, can bring palliative care in to do an outpatient clinic in their setting, or even a standalone clinic, which many of our programs have. And then we have community-based or home-based palliative care, and that's where a provider and or a palliative care team is going into the individual home of the patient. And that can include, for traditional palliative care billing Part B services, skilled nursing facility, unlike GUIDE, assisted living, independent living, or an individual residence. And so again, inpatient palliative care in the hospital, stabilized support, disposition or discharge planning, outpatient palliative care clinic setting, you go to that, or home-based palliative care comes to you.
Mm-hmm. Absolutely. And locally, if I can add anything, what I'd say for our region right now, we are the only home-based palliative care program in this area. TMH, or one of the local hospital systems here, they have a palliative care team on site. And like Chris says, the focus is to, stabilize the patient and start to have those advanced care planning conversations, so the team can understand, well, what kind of support does the patient need? Do they need to be connected to hospice care, or do they need to continue to receive palliative care support, or whatever other support they could benefit from? The hospital team helps them there. I'm not too sure if HCA or other hospital system here has a palliative care team on site. I think they have providers consulting in the hospital, but oftentimes the care starts and stops at the hospital, at least for the two hospitals we have in town. But in our program, we meet the patient, oftentimes at home, wherever they call home, and we continue to follow them for as long as they need our support.
Thank you.
Thank you.
Now have an entry from Carlos Olivas. Thank you, Carlos. I'll read it. We have Dad enrolled in palliative care. The MSW has been great in guiding me through some difficult times. How do we close the gaps between the family care partners and the palliative care teams? How do we break down the stereotypes and stigmas that are associated with palliative care and hospice care? Take it away, Fab.
Yeah, that's a great question, Carlos. Thank you. Can you keep the question
Yeah, that would be
broadcasting?
helpful. Thank you.
Thank you so much. So how do you close the gaps between the family care partners and the palliative care team? Right. So I imagine you're talking about family care partners. So I'm wondering if you're talking about the caregivers to the patient, so maybe like yourself and family members, or you're talking about maybe providers the patient is connected to, so primary care physicians and other specialists. So I would say so on the family side of things, I would say whoever is in charge of who's assigned the role of primary caregiver should really be communicating with the social worker, and they could really use the social worker if they feel like there is the fit is not right with the nurse practitioner. They could really be communicating with the social worker to help to get to the right provider that could be, helping the patient and family more meaningfully. So that's one way to engage it. And also, what issues, I guess, what support do you fear that, are you worried that you're not receiving, that you think you need to be receiving? Are you asking for help and the help is not coming to you quickly enough? Or, I would love to learn more about that. And how do you break down the stereotypes and stigmas that are associated with palliative care and hospice care? Another great question. So with that one, I would say palliative care, as we've mentioned before, it adds an extra layer of support. It does not take away. It's supposed to help make the care journey, easier, more manageable, not only for the patient, but for the caregiver. And hospice is really reserved for end of life. So we're talking 6 months, or less of life to live. It's really extensive care provided where treatment may not be an option anymore. So with hospice care, there is this foregoing of treatment, and also really committing to preparing for end of life. Whereas with palliative care, where treatment is still oftentimes at play, and patients and families can continue to receive treatment, get the support of the palliative care team, talk about goals, and have the backing of the palliative care team to help communicate with their primary and their specialist. So we work in collaboration with the care team the patient has on the palliative care side. We don't stop. Those relationships don't end when the patient come on to palliative care. I know that was a lot of information. Chris, anything to add to either one of those questions?
Yeah, and again, I think Carlos just put this in, and there is this fear. So I'm going to take this from a couple of lenses. One, the more people that use hospice and have a positive hospice experience, the more we break down those stereotypes.
Mm-hmm.
And it is an entitlement benefit, Medicare and Medicaid. So anybody who is over 65 is entitled to the benefit through Medicare. And unfortunately, hospice is often thought of brink of death. Like, oh, somebody went to hospice. And often what that means is they waited too long. And when they went to hospice, their symptoms were too great to manage in the home. And they went to either the hospital or to a beautiful inpatient unit like, Big Bend and Alleviate Care have, community hospice has. But that's not the design of hospice. 6 months. And I will share this to break down the stereotype. Because again, not break it down. My wife's grandmother, who's beloved, dear, now, has passed on. She graduated from hospice 3 times. 99 years old. She was no longer eligible for hospice. And she passed away just months before her 100th birthday. I kept saying, Grandma, you're so close. But she graduated 3 times. So she started hospice when she was 96. And then her care improved. And again, that often will happen with hospice because of the interdisciplinary team with all the support. Somebody may stabilize, maybe their disease progression, slows, and they end up improving. And then she stepped down to palliative care, went back on hospice when her care needs graduated again, and then finally was served by hospice for the last 3 months until she did pass. That's a perfect hospice experience, right? With palliative care weaved in the middle of that. And actually, we often will say in the world of hospice and palliative care is not hospice. Hospice is a very defined benefit with very defined criteria, but hospice is palliative care, meaning that same consistent extra layer support is carried into the hospice benefit and that hospice experience.
Thank
Now,
you.
The break down the stereotypes, encourage your friends, your neighbors, anybody. Hospice is not something to be scared of.
Yeah.
Okay. Question for you, Chris. Are there any restrictions in receiving palliative care when the resident is in a long-term assisted care facility?
So there are, and there's some that are very operational / detail focused that may not be that relevant to the audience today. But in order in a long-term care facility that is licensed by the state and receiving Medicare funds for that short-term rehab, as well as Medicaid funds for long-term care, there are specific criteria for providers like community hospice, Alleviate Care, like Big Bend, to be credentialed and contracted in a nursing facility that at times can limit our ability to serve there, because the nursing facility may or may not grant us a contract. And so if you're in that situation and your loved one's in a skilled nursing facility and you want to work with a program like Transitions Big Bend, you may have to go to administration and say, it's my preference that this program come in. There are also some billing changes happening with Medicare that are now requiring nursing facilities, skilled nursing facilities, to start providing more care. Medicare looking at how they reduce, we'll call it overlap or redundancy, and things that should be provided or are already being paid to the nursing facility. And so again, those nuances are starting to take where the nursing facility may be doing some more palliative care. We see a lot of nursing facilities starting to spin up or start providing some of that support through their extensivist service or the medical director in the team that's there. And that would be the one limitation. Medicare doesn't want to pay for things twice.
That's right.
Anything to add, Fab?
Yeah, I'll say that in our current state, we're not going to skilled nursing facilities in our areas because of that very reason that Chris just spoke of. These facilities said they were providing palliative care support already, when it was the caregivers of these residents who are reaching out to our team saying that they needed more, their loved ones needed more care. And of course, because Chris said, like he said before, Medicare won't pay for, care twice. They would not allow us to go in because they likely were, maybe billing for these services, and they did not want to be or involvement.
Wow, go ahead, Chris.
I was going to say, and one of the challenges in both the organization that Fabiola works for as well as the organization I work for are both community-based, not-for-profit organizations, and much of the palliative care movement, if you will, as well as the providers across the country, started out of not-for-profit organizations like ours or not-for-profit health systems, because the reimbursement mechanisms, as we talked about, mirror or are really the same as traditional physician practices and often don't cover the costs of delivering palliative care. And so that's, again, another limitation or challenge is depending on where you're at, there may or may not be an organization like Fabiola's or mine that's really providing this care as a community benefit, because we in no way cover the cost of delivering the service.
Thank you. Well, we're rounding the bend here, folks. What I'm going to ask is for each of the presenters to give a final thought, and I'll give mine as well. Let's start with you, Tomeka Norton-Brown.
My final thought will be, as Chris mentioned before, in order to remove stigma, you have to talk about things. You have to be willing to talk about it, and then willing and open-minded to listen and receive information. So I am very big on taking advantage of resources that are available. And if you're watching this and if you have questions, please reach out and I will put you in touch with either Fabiola or Chris just to make sure that your questions are answered.
Thank you, T. Fabiola, please, your final thought.
Yeah. I would say again, please don't delay. Please don't wait till a crisis occurs to seek out support. And really, there's help available. If only you would open yourself to learning more about how these resources can benefit you and your loved one, such as palliative care, hospice care when the time comes. But help is out there. It is not something to be afraid of. Please seek support.
Thank you, Fabiola.
Thank you.
Chris Morissette.
And I would conclude by saying, for those of you that are family caregivers or providing care, thank you. You have a hard job providing the support to your loved one. If you're yourself going through a serious illness, there is support for you, and you're not alone. And I will say this, for as long as I've had the opportunity to be in a healthcare role, I have not met a single family or individual who has journeyed a serious illness that regrets using palliative care or hospice. Not all experiences are 100%. No provider is perfect. But in the end, I have never had somebody say, man, I wish I wouldn't have done that. Because providing the support, and here's the other thing, doing it alone doesn't win you any extra points, right? What it does is create extra stress. It adds extra stress on you, your family, your caregiver system. And so you have this benefit before you, as Fabiola said, and Tomeka said, use it. In many cases, it won't cost you anything. So take advantage.
Absolutely.
I'll get back to T. Any further comments? Because that might have resonated with you, maybe with Fabiola too. I don't know if I'm reading your mind, but probably not.
No, I mean, everything we've been saying is help is out there. Please open yourselves up to seeking that help. And the journey can be long for some, but there is help along the way. So like Chris said, there is I hate to say the word medal for doing it yourself or doing it the hard way. There is help, and it's okay. I think it's a strength to say that I've been doing this, but I need help. And not only does it benefit the caregiver, it also benefit the patient. So, please reach out.
One thing I would add is be an informed participant. Medicare believes in transparency. So you can go on to things like Hospice Compare or Physician Compare. We can provide some of those resources. I'm sure T probably have that already built in the X2 platform as well. But to go in and understand before you make a selection on which palliative care provider or physician, be informed. You can do the same thing with Hospital Compare. Know how good, what the star ratings are of the healthcare provider that's going to be delivering care. So you remove some of those barriers or those concerns. And again, we shop Amazon reviews, right? You think about the last time you bought something on Amazon, you probably scoured the Amazon reviews for you. Same thing with your healthcare. You have the ability. Medicare's transparent. It's all before you. Go to the Physician Compare, Hospital Compare, Hospice Compare, and it's all there.
Thank you, Chris. I wanted to thank Emma Smith for her affirmation. Good information, folks. Thank you. I'll be the choir on that. I want to echo that. Excellent information. Wonderful.
Thank you.
Tomeka, is there anything else you want to say?
No, I think that it's all been summed up very nicely. As I said before, you don't have to do this alone. Even if you don't know where to start, just give us a call and I will make sure to get you connected with the folks that can help you.
Thank you, T. Well, just a couple points that I'd like to leave you with. One is that this wonderful workshop, thank you, Fabiola, thank you, Chris and Tomeka, will be available on the X2 YouTube site. It's called X2 Caregiver Project. You click the live tab. We will be transferring, and I think it may actually happen almost automatically. Am I correct with that, Esperance? You could just put in the chat. Esperance is in the background here. Yes, okay, it's going to transfer. I got a yes from Esperance. So if there were portions of this that you missed, or if you do what I do, I listen to the workshop as I'm going through it with each workshop that we do. But then right after 8:30ish, 8:45, I'm listening to it again because I know that I've missed so much during the course of that workshop, just needing to come up with questions. At any rate, that you will have a recording at our X2 Caregiver Project. That's the name of the YouTube site. Immediately after or close to the closing of this workshop. That's number one. Number two, I would encourage folks that please follow us on the X2 Caregiver Project Facebook website. Why? Our next workshop, I think, might be of interest to you. We're going to focus on we'll have our next speakers focusing. This will take place August 13th of this year on strategies for enhancing the relationships between persons living with dementia and their family care partners, particularly using innovative ways to meet the needs of loved ones with dementia while enhancing self-care for the family care partners. And Dr. Linda Miles and Pastor Brett Cooper will be joining us, as well as other guests, August 13th of this year. So please join us for that. And with that, I'd like to say thank you to our panelists. Thank you to those who joined us. And I also, as a final, would request that Esperance Villafuerte and Melissa Powell would please join us so that we can thank you for your work behind the scenes. Please join us at this point in time, if possible.
Hi, everyone. It's great. We're always thankful doing this live stream workshop for y'all. It's a pleasure, and we love getting this information out to everyone. So much love to you all, and thank you guys for all being here.
Thank you.
Melissa?
What she said. Yeah, no, thank you guys for being here. All these workshops are always great, and it's a great thing to be a part of. So
Esperance is our social media coordinator, is the person who makes these productions possible. And Melissa Powell is a long-term volunteer in doing this. She used to be at the College of Medicine, now at Education, Health and Human Sciences at Florida State University. And she pumps the slides and helps reconfigure slides and is just a great colleague and friend. So with that, I thank you and have a very blessed evening.
Thank you. Same to you. Bye, everyone.
Bye-bye.